Hi guys, Dr. Douglas Gillard here. I hate to say this, but we have to make this up. We were off on Tuesday. We missed a lot this week. I'm behind, so it's not going to be too bad. I'm just going to cover celiac disease in this YouTube video, and then we'll pick up on Monday. We're going to have a very busy week next week, though, because we need to catch up. So here's celiac disease. This will be on your final, so make sure you watch this video. I'll send you the link, of course. All right, here we go. So celiac disease. OMG, look at all the AKAs. Celiac disease is a confusing term because the literature can't agree on a single term for it. Robbins calls it celiac sprue. Celiac disease, Schleisinger, probably a better term for it. There's non-tropical. There's a tropical sprue we're not going to talk about. It's often called non-tropical sprue. Gluten sensitive enteropathy is another one Robbins uses. That's a long time board book. So gluten intolerance, celiac syndrome, adult celiac disease, etc., etc. So I'm calling it celiac disease. Let's just keep it simple. But just be aware for boards and things, it could be called celiac sprue or non-tropical sprue or gluten sensitive enteropathy. What is it? It is a chronic, we think it is, we're not 100% sure what it is, but we have some ideas. So it gets a definition of a chronic T cell mediated inflammatory disease with an autoimmune component. There's definitely an autoimmune attack involved in this on the enterocytes of the small intestine. Robbins calls it an immune mediated enteropathy. Occurs in genetically sensitive people. You have to have some type of genetic sensitivity to this because everybody doesn't get it. And you can develop a sensitivity as well. You're not maybe not just born with it, but it's some specific protein antigen, namely, as we'll see, it's an antigen against gluten. Although, is it really gluten? Now we're going to get into my little rant about gluten here in a second. But generically, you'll hear the word gluten. That's not really a biologically correct term, though. Specifically, it's against specific proteins that come from the seeds of certain grain cereals. Who are the grain cereals? This is definitely boards and nutritional boards and my test and it'd be everywhere. It's wheat, barley, and rye. Oatmeal is okay. They used to when I back in the day they used to think oatmeal was part of it too, but we don't think that anymore. So wheat, barley, and rye. So the digestion of these cereals release a gluten component, and we'll see what that is in a minute, in the small intestines, which in turn it gets absorbed into the small intestine, into the enterocytes, that's into the epithelial lining, and it causes a destructive, almost an autoimmune type response to it. All right, so the inflammation then interferes. If you got an inflammation going on in your intestinal lining, you're going to have trouble absorbing nutrients, and that's especially in kids. You can get a malnutrition type thing from this. So the inflammation then interferes with the ability of the enterocytes to absorb nutrients. Okay, there's the culprits there, the key grain cereals, the seeds of these barley, wheat, and rye. We'll break it down even further here. So what the heck, what is the story with this gluten stuff? So you've undoubtedly heard celiac disease is a response to gluten in the digestive tract, but that's only partially true. So what the heck is gluten? Technically speaking, it's various cereal grain storage proteins that are found. It's not just the gluten, because gluten, biologically speaking, gluten is only found in wheat. So what about the other guys? What about barley? What about rye? So they have some gluten too, as we'll see here in a second, but it's not all about gluten. Okay, what am I saying here? No, so technically speaking, there's no such thing as wheat or barley gluten, because wheat gluten only comes from wheat. So I don't know how this got ingrained in the literature, but it's pretty strong, but it's not right. It drives me crazy. Geek alert, so watch out. So in reality, many scientific, or in strict scientific terms, gluten is one of many components of wheat cereal, but there are many different proteins that fall under the heading of gluten. Not all of them are allergic or allergenic, so they don't all cause this reaction. There are two subgroups of gluten that are troublesome, which we'll look at. From all the proteins under those subgroups, there are only two proteins that are troublesome when it comes to wheat. So let's look at, that wasn't the greatest slide in the world. Let's put it into better terms. So the gluten's true composition. So these are the key wheat and gluten proteins. There's several subdivisions of these proteins. One is the glutenins and the other is the prolamins. Prolamins is the big one. But with regard to just wheat, not only gliadin, but this glutenin these are both troublesome proteins that react. They can be absorbed and they can cause an inflammation process. All right, so wheat gluten is very elastic. What is gluten anyway in general? This is kind of out of place statement, but it's a stretchy material. It's what allows the wheat to stretch when you're baking it. So it's got a stretchy component to it. Gliadin, spelled gliadin, I call it gliadin. Gliadin is the protein that causes the most trouble. This is definitely the one that's most studied, but it's not the only one. So the research world has been using the term gluten imprecisely for many, many years, and it's even in most of the pathology books. Only the highest level pathology books actually have this right. Okay, specifically they've been using words like gluten to describe any type of prolamin from any type of cereal grain, and that's not correct. So there's corn prolamins and wheat and rice, etc. However, because board books don't, I'm not going to, this is my only rant, so you can ignore all that stuff. I'm not going to, go off on the deep end in this stuff. I'll use the word gluten to include all cereal grain prolamins. But just remember, really strictly speaking, gluten is only talking about wheat. All right, so that said, who are these prolamins? Because the prolamins is actually a way better term than gluten. Prolamins works. So they're a group of plant storage proteins which are found in the cereal grains. They in particular have two very troublesome amino acids, proline and glutamine. Proline and glutamine don't like the digestive tract. So enterocytes, which again line the intestines, right? They make up, enterocytes are nothing more than epithelial cells that line, we just talked about that a lot already, that line the digestive system. They have a tough time with proline and glutamine. They can't digest them well. So only the prolamins from wheat, barley, and rye cause celiac disease. That's kind of out of place, but that's true. Oat prolamins, this is like a kind of fun fact slide, I guess. Oat prolamins have been a little controversy in the past, but now they're safe to eat. We said that right. Rice and corn prolamins, perfectly safe to eat. 4 antigens of celiac disease. So specifically, the problematic prolamins are the gliadin. I keep pronouncing that wrong. I'm used to saying it gliadin. It's gliadin. And then we have saccharine in rye and this hordein in barley. These are responsible for the symptoms of celiac disease. Okay, so it's really prolamins better than to say galactic. Okay, to be 100% conclusive, there's one more. We have to add another antigen that comes from the wheat agglutinin group called glutenin, not gluten, glutenin. Okay, so that if you add these 4 right here, these are the real antigens of celiac disease. 2 stars, I'm going to test you on that. Okay, so it's it's prolamins mainly, but this is not glutenin is not a prolamin. This comes from a different group called the glutenin group. Okay, but these are the culprits right here, these four. Okay, there's if you're biology major or into this stuff, here's the family tree, and there's the wheat, rye, barley. Oats was similar, but oats is okay. This will, I think I got a couple slides coming. All right, so all that, push all that stuff aside. Let's get into a little bit more meaty stuff here. So there's a big European study done on celiac disease not too long ago. It came out, there was a little bit of variation, but about 1% of the population suffers from this. And you know what? So why are we making such a big deal about celiac disease and gluten? Because some people suffer terribly from this. There's a dermatitis associated with this. It can be really, really bad. So that's why it's a big deal about this. The prevalence has also been on the rise worldwide. We're not sure what the deal is with that. In fact, it's fourfold increase since the 1950s. Possibly got to do with environment. We're not sure what the cause of that is, but it's just like the new news today or yesterday, right? The incidence of colon cancer in young people has doubled since the 1990s. Another thing on the rise. We don't know what that's all about. So this one's also on the rise. It affects all races pretty much equally. In adults, the prevalence appears to be a little bit greater than women than in men, believed to be probably secondary to menstruation, which decreases the iron even more than it's already being decreased, and vitamin absorption. Somewhat lower prevalence in countries that have a rice-based diet. Rice is, there's no question, rice does not have anything to do with this disease. So some of the countries that eat rice seem to do better, have less prevalence than others. So pathogenicity and susceptible people, the prolamins of wheat, rice, and barley are usually resistant to gastrointestinal enzymes. Remember, the gastrointestinal enzymes in the intestine are weird. They don't get released into the, float around in the intestine. They're actually embedded in the brush border of the enterocytes. So these prolamins of wheat, rye, and barley, they're resistant to the enzymes. They don't get broken down. It's not to say they don't get taken in, and that's the problem. But it's probably, we're not 100% sure, but we think it's because of the high concentration of proline and glutamine, which enzymes don't like. The enzymes embedded in the brush border, the enterocytes, don't like them and they can't handle them. So the problem is that the proteins still get in, but they're undigested. They still get sucked in to the enterocytes, and that is where the problem occurs. So these undigested prolamins in the intestinal mucosa, they are seen as evil. They're not digested. In some people, not everybody, but in some people it sets off the alarms and it stirs up the immune system. Both the adaptive and the adaptive, or the innate and the adaptive immune system are turned on, and now we got an autoimmune type inflammation attack against your own intestine. So you get cytokines coming in, you get damage, you get remodeling, which we'll look at. You can see this under the microscope in people with this disease, what it looks like. It flattens out the tops, as we'll see. But why some people are susceptible and can break down prolamins and others can't, we just don't know the answer to that yet. So now our geek alert. One of the key elements in the pathogenicity of celiac disease is the activation of lamina propria T cells get turned on like crazy, and that again secondary to these undigested prolamins or partially digested. Specifically, this T cell activation occurs in response to prolamins that are being gobbled up and then presented. Remember, when T cells eat these prolamins, they are well, they're when like a macrophage. These are antigen presenting cells, macrophage and B cells. They will gobble up the prolamins and raise them up on their cell membrane and present them. That's why these are called antigen presenting cells. And so that is a problem. Okay, there are two, or so they're presented when they're raised up on the, I always say raised up on the flagpole. They're after they're eaten, they're raised up, and they're presented so lymphocytes can come and eat them. But they're presented as two forms. There's two major histocompatibility complexes, HLAs, that are unique to patients. So they're presented in a weird way. We've all heard of HLA-B27, but they're presented as a HLA-DQ2, DQ8. I call them Dairy Queen 2 and Dairy Queen 8. That's very characteristic of someone with celiac disease. So if you see antigen presenting cells with these HLAs on their cell membrane, that's a strong clue that the patient has celiac disease. Okay, I hope everybody understood that. Okay, the first step to making the diagnosis is serology. So you order some blood work, and you can order, it's an ELISA assay test, and you're looking for the following things. There are some celiac disease specific autoantibodies that are present. There's anti-TG2, anti-EMAS, anti-DGPS. So these all will be present. So these are antibodies circulating in your bloodstream that are known to attack the small intestine. Those will be present. You should also get IgA levels. This is also elevated in patients with celiac disease as well. Okay, so autoantibodies, these are the autoantibodies. You don't need to memorize this full name, but you should know anti-TG2, anti-EMAS, and anti-DGPS. If those are present, the patient's probably got celiac disease. And if the IgA levels are elevated, probably got celiac disease as well. And we already said you can do some cell typing. You can order cell typing, because we already said there are two major histability complexes on antigen presenting cells like macrophage that may show up. So if you see Dairy Queen 2 or Dairy Queen 8, Dairy Queen 8, HLA-DQ2, is present in 90% of patients with celiac disease. Dairy Queen 8, 95%. So these are very strong. They're very strong findings. In fact, less than 2% of celiac disease patients fail to have at least one of those markers. There's a problem with that test, though. The problem is it has very low specificity. What does that mean? There's a big false positive. The sensitivity is good. It's 90%. So you guys have had your statistics class. You should know what that means. If the sensitivity is really high, then it's a great tool for ruling out celiac disease. If these markers come back as positive, that's not such a great thing, because the rate of false positive, it may be well be a false positive. Comes back negative, the rate of false negatives is not very good, or is very unlikely. So if you're negative, you don't have celiac disease based on these two markers. Okay, that makes sense. Histological appearance, so we can old-fashioned, you can go in there with the endoscope and take some tissue samples out and get an endoscopic biopsy for analysis. What do you see? There is a flattening of the villi of the enterocytes, and the brush border is basically destroyed. This is a very characteristic finding of them. Remember, enterocytes are simple columnar epithelium. That's converted into cuboidal or even squamous type tissue. Okay, remember our basic GI physiology? Okay, there's a villus. This is all the enterocytes that we've been talking about. Those are right there. And the villus is lined up here. We're in the mucosal layer. There's the basal lamina here. Muscularis propria is underneath that. We can't see it. It's not important right now. Lacteal isn't drawn in here, but normally we have a lacteal, and there's the blood vessels. Okay, so there's all the cells. If you look really close, you can see little hairs on the top of all these enterocytes. That's the so-called brush border where all the enzymes are. And that's where food particles are broken down and sucked in. When you have carbohydrates, fat, proteins, they all get broken down right here in the small intestine. I mean, it helps. There's some stomach enzymes, of course, pancreatic juice helps. But the bottom line is, this is the bottom line. This is where they get in. Amino acids get into the blood. Monosaccharides get into the blood. So this is very important. Now, here's a normal cartoon. Here's someone with celiac disease. When you do a histological sample, there's no brush border. Uh, the the villi are like somebody chopped them off, very stubby looking. So it's quite characteristic here. Enterocyte production from the stem cells also cranks up. Remember, stem cells give rise to those enterocytes. So it's almost like psoriasis. You start making more and more and more of these things. So if you're making these so much faster, you're going to get premature shedding of the enterocytes. There's no room for them to go, so they start sloughing off. And we think that's got something to do with this the shortening and flattening effect. You also get, I didn't put this in here, but you also get the crypts of Lieberkühn get really, really deep. See, a normal one, they're not deeper than the villus. But in someone with celiac disease, they get really, really deep. And it almost gives a false appearance that the villus is okay, but it's not. It's because the crypts are so deep. But I didn't put that in. I'm not gonna. That's histology stuff. I'm sure you've had that before. Okay, the tight junctions that hold enterocytes together also get beat up from the autoimmune attack, and therefore they start leaking and they let bugs in easier, so you can get an infection much easier as well. The inside the cells themselves, the enterocyte endoplasmic reticulums get beat up, and therefore they don't make as many digestive enzymes to go on the brush border, which is beat up anyway. So the bottom line is you're unable to properly digest food. If you can't break down food, it goes through and becomes like a diarrhea type thing. So you get diarrhea from this disease. Kids can get malnutrition. They can have their growth stunted and all sorts of things from this. Why? All because of this darn inflammation. It's your body doing the attacking when, I mean, it really shouldn't be attacking. Most people aren't sensitive to those antigens. Okay, and I'm not going to test you on this, but here, if you really get deep into a histology thing, there's a normal villus. Type 1 is starting to get a little funky, a little beat up. Type 2, now these crypts of Lieberkühn are getting deeper. The top is starting to get funny looking. Type 3, now the top is flat. Type 4, the type is really flat. Is this a permanent thing? Are you doomed forever? No. You can actually recover even from type 4 by doing one simple thing. Don't want to spoil my slides, but you just stop eating whatever's causing the problem. Just stop eating the prolamins. Okay, here's a histological sample. Here's a case in point. Here's a patient with the villi are flattened. Patient with celiac disease. They stopped eating the prolamins, and 6 months later, a repeat sample was taken, and it looks a heck of a lot better, doesn't it? They're a little flat still, but you can see it's greatly recovered. So you can recover from this, which is great. Clinical features. You guys know I like clinical features. Heterogeneity. What does that mean, heterogeneity? I might put that in the test, so you better know that word. That just means there's a lot of different presentations. Not everybody presents exactly the same. So there's incredible heterogeneity in this condition. It can present from many different ways. That's why it can take years to make the proper diagnosis, because it's hard for primary family docs to figure this out. There can be so many different. We'll look at the symptoms here in a second. Why is there such heterogeneity? Because there's a complex. They think there's just everybody interacts different with the environment. Everybody has a little different genetics. There's immune factors, so everybody's unique and reacts differently. So what are the adult symptoms? Well, maybe they don't have any symptoms. Kids usually have the symptoms. You can grow out of the symptoms, but you can still have the disease. But the typical symptoms are going to be diarrhea, bloating of the abdomen because of all the gas undigested. The bacteria are having a field day. They're getting to eat some really good food that's usually they don't get to because it gets sucked in through the enterocytes. Fatigue, you don't feel good. You have anemia, malabsorption, you're not getting the proper proteins and amino acids are missing, and you have all sorts of malabsorption, so you don't feel good and you have anemia. About 12% of the patients, that's a decent chunk of these people, also have a rat problem with a nasty rash. We'll talk about that more. I teach dermatology. We'll talk about that in seventh quarter. But or actually, I think I took it out. We'll talk about it now since we're right here. Uh, Dermatitis herpetiformis. So dermatitis herpetiformis. Dermatitis herpetiformis. DH, designated hitter, DH, dermatitis herpetiformis. So there's a bunch of AKAs for it, and when it gets going, it has a lot of morbidity. It's a very nasty. It causes a wicked burning, and it is quite pruritic. What's that mean, pruritic? Itchy like crazy, and you get these vesicles. It almost looks like a herpes outbreak, as we'll see here in a second. It is characterized, if you take a tissue sample, you'll see tons of IgA living within, this is an antigen, right? Living within the dermal papillae. IgA is one of the ringleaders of the inflammation process, so it's a mediator of inflammation. Okay, some facts about it. The onset typically shows up in the second, third decade of life, so in the teens and 20s. It likes males a little bit over females. The population prevalence is with people without just a general sample of the population, it's really rare. It's only in about 10% or 0.01, about like Marfan syndrome, 0.01% of the population. But remember, in patients with celiac disease, it's actually 12%, not 10%. There's a new paper I stuck in here based on a Mayo Clinic study that recently came out. So it's up a little from the 10%. So it's big time present in people with celiac disease. It tends blacks and Asians tend to be a little more immune from this disease. It has a very similar HLA profile to patients with celiac disease. In other words, their antigen presenting cells, their macrophages running around, they will have Dairy Queen 2 and 8, just like people with celiac disease. So people have with this, now we're just talking purely from a dermatology perspective right now. So people with dermatitis herpetiformis, about 25% of them have a documented malabsorption problem. So maybe they haven't been diagnosed with celiac disease, but they're still not absorbing things. They still have diarrhea and problems like that. 60%, if you go in there endoscopically, have bowel wall atrophy with lymphocytes running wild in there as well. So very similar to celiac disease. So here's some pictures. You can see this is more the early stages of it. It just looks like a run-of-the-mill, we'll learn this in dermatology, but the maculopapular rash, which it doesn't look too bad here, but you'll see we'll see some more stuff here in a second. Clinically, initially presents with a few itchy papules and vesicles. These are lesions greater than 1 mil, or what is that? Is it 3 millimeters? My brain I just had it is 1 centimeter. There's different ways to break this down. Some say a half a centimeter, some say a full. So we're using Chiropractic Dermatology Board book says 1 centimeter. So they're 1 centimeter. This one has fluid in it. This one's not. These are raised lesions. We'll talk about that more in dermatology though. With time, however, these can come together and form a pretty wicked rash with quite a lot of fluid, much larger. You get urticaria. You get papules, you get vesicles, so it's a full-blown rash at this point. Patients often get misdiagnosed. It's very painful and itchy, so they think they have herpes zoster, or maybe it's just an outbreak of herpes simplex. So here's a patient, 48-year-old patient with low back pain, comes to your office. He's known to have celiac disease. He also has an itchy rash on his gluteal region. So that's it. He's one of those 12%. He's got that rash. Here's another patient. He's got some really bulla starting to form here. Resembles herpes simplex. We'll see when we get to dermatology, but it's not. It's dermatitis herpetiformis. There's a patient that's got it pretty bad around their lips. Okay, treatment. There's some drug treatments. One called dapasone. It's probably the most effective medication to calm down those lesions. Problems with it is it can cause a distal motor neuropathy in some patients. Doesn't happen all the time, but it's a wicked. We'll learn radiculopathy, neuropathy. When you have the real deal, EMG, NCV positive radiculopathy or neuropathy, it's very difficult to treat. So there's some other families. This sulfone family, like sulfapyridine, is also pretty good at calming down the lesions. Doesn't work as well, but it doesn't cause the neuropathy. The big one here that's in red, I mean, just stop them from eating anything with gluten in it. So none of the prolamins, right? No barley, no wheat, no rye. And then that's the most effective treatment you can have. Sometimes the third option is to introduce antibiotics, which isn't effective as these two, but there's no chance of developing a neuropathy with them. And okay, that's about all I wanted to say there. In children, a lot of this is from Wiley. This is a great book, by the way. This author Wiley, I really, really like him. Much better than Robbins, much more precise, and the team who's written the book really like it. Trouble is, it's for children and adolescents, but a lot of the stuff still applies. Very evidence-based. Anyway, so children, it can be very difficult to diagnose too. It can present like irritable bowel syndrome, Crohn's disease. You don't know what's going on with the patients. Symptoms typically start about 15 months in after they start eating wheat or rye or barley. One of the prolamins in there is causing trouble. It doesn't show up right away because they're really not eating solids yet. Classic signs are kind of the same for the adults. They have bloating, abdominal distension. They have chronic diarrhea. But now they're little guys. They're growing now, right? So adults don't really have this, but they may have failure to thrive. They're getting malabsorption. They can't. Their intestines aren't working. So now they're starting to waste away. They're getting anorexic, having all sorts of trouble. Okay, they can even have vomiting was on the list. They can have joint pain. Maybe that's what brings them into your office. They can be cranky, of course, because of all these other symptoms. Okay, intestinal symptoms, they do have a tendency to subside. The child can grow out of these, but the problem is still hiding away there. The problems can become extraintestinal at this point as well. So from years of this, you can develop a real iron deficiency anemia from this disease. Arthritises and arthralgias are also really common to go right through the teen years and kid years and keep right on going. So maybe someone with coming in with joint pain and they've been to every doctor in the world, no one can figure it out. Maybe it's celiac disease. It's been associated with the development of a metabolic osteoporosis as well, probably because of the malabsorption of calcium, but there's some other factors in there as well. Epilepsy and gluten ataxia have been described without taking the medication for this, so there's some other neurological signs that have been involved. Peripheral neuropathies, again, not from the medication, have been described. Liver problems liver failure has been reported. Fertility problems, dental, alopecia areata we'll talk about in 7th quarter, but those are little circles of hair loss on the scalp and eyebrows, it could be in the beard. And the oats, here's a little side thing on oats here. For a long time, there's a raging debate. Oats were thought to be the cause, or uh, as was wheat and barley, but nowadays it's been pretty much ruled out that the prolamins of oat are okay to eat. Rarely some celiac patients had flare-ups from oat diets, but when you traced it back to the plant, they were mixing the oats, and maybe the batch before was a wheat batch or a rye or barley. So they think it was some contamination and not really the oats themselves. Okay, so cross contamination in the manufacturing, you have to be very careful of that. And let's see, cereal proteins of oats. Now there's one mystery. See, Mr. Spock is like, what's going on here? So there's a mystery. The prolamin fraction of oats also contains glutamine and proline, high levels of it. What? Didn't I just say that it was the glutamine and the proline that caused the problems? Well, oats have the same high levels, yet we know pretty much now that this is not the problem. So what does that mean? There's an area of research we don't know. We don't understand everything about this celiac disease yet, because here's a case where the body can absorb the glutamine and proline, but you switch over to wheat, which also has high levels of glutamine and proline, and they can't absorb it. So there's another factor we're missing that still needs to be worked out. Some associations here. So if your patient was diagnosed with celiac disease, you might, and they don't have these conditions, you might consider testing for them. Thyroid disease, Addison's, other autoimmune diseases, pernicious anemia. You got to raise your eyebrow to all of these. Type 1 diabetes mellitus. These diseases all increase the risk for celiac disease, and people with celiac disease have an increased risk for these diseases as well. Some alopecia, where we said alopecia areata, we already talked about that. Cardiomyopathies. Okay, so all these conditions must be ruled out or investigated in a patient, especially thyroid disease and Addison's disease and pernicious anemia and diabetes. The ones in red are probably the ones that you should focus on. Treatment. What do you do about celiac disease? Well, treatment's pretty easy. We talked about a little bit the medication already. I guess we're talking more about it now. So you got to remove the prolamins, remove the wheat, the rye, and the barley prolamins, and that's it. That's all you have to do, and the patient will get better. So that's it. Avoid malt. So malt you have to be careful with unless it is clearly labeled as it came from corn, because I guess wheat and barley can be involved in this process. So watch out for malt as well. Which foods are safe? So rice, corn is safe, buckwheat is safe, potatoes, soybean. And there's a question I asked a question on the last quarter about this. So you should definitely know these. I should put a star here. Rice and corn are fine. Buckwheat's okay. Potatoes, soybeans, tapioca, beans. Should have purpled that one too. What is not safe to drink? So fortunately, beer, lager, all you beer people out there, you can't drink beer. Even stouts, none of the beer at all has prolamins in it, or the so-called um, I will just keep calling them prolamins. Soup, candy, there's some other weird ones. Gravy, herbal tea, lip balm. You have to be careful with some lip balm containing the prolamins. Play-Doh, salad dressing, soy sauce. I mean, having celiac disease is a bummer because there's a lot of stuff that you can't eat, and it doesn't take much to set off really bad reactions. Which drinks are safe? You can drink wine. Most liquors you're good. Ciders, spirits like whiskey and brandy are good. Hey, we're done. See, that wasn't too bad, right? Okay, so make sure you watch this, study this, just like if I was standing before you and lecturing, because you're going to get tested on this. Okay, I'll see you on Monday.